This is Andrea Kane, and I'm here with you for HIT 292 Reimbursement Systems. We are on week 12, chapter 7, and this is lecture video number 5 out of 7, I believe. And we are talking about end-stage renal disease and how that has a prospective payment system with it. If you're following along in your book, we're on the page 173. End-stage renal disease. Benefits for these patients have been included under Medicare since 1972. End-stage renal disease means these are persons who have permanent kidney failure that requires either dialysis or kidney transplant to maintain their life, regardless of their age. In 2017, this also added persons with acute kidney injury. So why is there a PPS system for a specific condition? Well, in calendar year 2015, CMS spent over $11.2 billion for end-stage renal disease services in outpatient facilities, because these are patients who have to have dialysis several times a week. And the cost of kidney transplantation and the follow-up care that goes into that is very expensive. So all the non-inpatient services for ESRD are included in this payment system. So anything outpatient, home health, all of that, it's all going to be in this ESRD PPS. Getting my letters mixed up. ESRD PPS is a case rate reimbursement methodology, sometimes referred to as a composite rate. But it's really case rate. Make sure you know case rate when you're talking about ESRD. Several adjustments will account for the patient and facility differences. It ensures that the reimbursement reflects costs, and adjustments are called patient multipliers in this system. And you can see this on page 174 at the top. They have facility and patient level adjustments for adults and facility and patient level adjustments for PEDS patients. And so example, a facility level adjustment would be a wage index or a low volume facility. A patient level adjustment would be patient age, body surface area, low body mass index, the fact that they're a new patient with an on-site of dialysis, and specified comorbidities. And I just covered that, sorry about that. Facility level payment modifiers. This is where you get into the labor or wage index and the low volume facility. And these numbers can get adjusted. And then the patient age, this shows us how age and cost are associated. So the youngest and the oldest categories are the most resource intensive. Body surface area, this has to do with some of the physical factors involving dialysis and the cost. When the patient's BMI is less than 18.5, then there's an adjustment made. Talking about new patients, because during the first 4 months of dialysis treatment, the costs are significantly higher, which makes sense. Think about somebody who's stepping into this and the kind of supervision that they need during their first 4 months of dialysis versus someone who's been on dialysis perhaps for years and is more on a stabilized basis. Note that there is a caveat here that if the patient is eligible for and receives the onset of dialysis adjustment, the application of that adjustment cancels out the activation of the comorbidity adjustment and the home training add-on provisions. So going into the comorbidity adjustment, there are 4 comorbidity categories that allow for a payment adjustment. And if a patient has more than one comorbidity, they're all into multiple comorbidity categories, then the category with the highest multiplier is used. So some examples are pericarditis, GI tract bleeding with hemorrhage, hereditary hemolytic or sickle cell anemia, myelodysplastic syndrome. These all, for example, these have the multiplier. So peds, they look at the combination of age and the modality of treatment that they're receiving, whether it's peritoneal dialysis or hemodialysis, and that goes into their payment multiplier. ESRD PPS has a couple of provisions. There's outliers, of course, and there's also self-dialysis training. And outliers start at the bottom of page 177 and go into the next page. Gives you some examples. And then self-dialysis training is here on page 179. There is a transitional drug add-on payment as well whenever there's new injectable or IV drugs and biologicals being used. The eligibility is that they have to be approved by the FDA, commercially available, have a HCPCS code, and qualify as a renal dialysis service. They must not be in an existing ESRD PPS functional category. So how do you calculate payment? Well, you have your wage index, you apply your payment modifiers, you multiply the patient modifier by the wage index base rate, then you multiply the adjusted base rate by the number of treatments, you apply the self-training add-on. If it applies, you apply the transitional drug add-on. If that applies, then you apply an outlier. If that applies, you sum the day rates plus the applicable add-on payments, and there you go. Hopefully, you never have to calculate that yourself. If you do, page 180 should be helpful to you, where it goes through step 1, adjusting for geographic factors, step 2, adjusting for patient and facility characteristics, and then step 3, policy adjustment for beneficiary encounters that qualify. And that is it for ESRD. Be back shortly with the next one, which will be on safety net providers.